Yep, and that's perfect. See, what she's done is she's rolled the thing around. And you know, often there's a side that shows more easily. It depends on, you know, what you've cut. Maybe the line isn't exactly underneath the line on the skin. And so sometimes you only have to retract on one side. So, but you're using good judgment there. Now that wasn't very good. I hope this doesn't get worldwide distribution because my hand position wasn't very good on that one. I'd hate to have the students say, but you said not to do that. And I'm just going to pretend that we're at the end now for the sake of our lesson, right? And now you want to tie your final knot. So I'm going to protect the needle. And I can either hold it in my hand or set it down. And now I'm going to tie a knot using the loop as the end. So we'll tie it this way, and this way, and this way, and this way. And we're done. So then we have the fat layer. We don't sew the fat together. Occasionally there's a layer of a certain kind of fascia that's in between these two fatty layers. And sometimes people have a nicely defined one, for instance, when they do hernia repairs, often the surgeons will make sure that that layer is nicely together. But for cesarean, no, we don't worry about that.
And it's important to have the fatter foam next to the vinyl? Does it matter which? Because there's a fat foam and a thin foam.
You know what? I'm not even sure that we need 2 layers for the model.
Well,
Did
I asked Dr. Lett, and he said he needed 2 layers because for anatomical reasons.
Yes, he's being strictly speaking correct, but
And he wanted the fattest layer, thickest layer.
yeah. Because there is in real life there's a layer that's there, and that's what he's looking at it from the surgeon's point of view and saying, okay, and under certain circumstances we might do this, but in C-section we don't do that. So I guess I could have a conversation with him about that. Okay, so I wanted to see you. So now we're going to close the skin. So how about if you put a stitch in for me here? You can do it.
Okay.
So I'll tie the knot for you.
Okay.
Okay, so the way you hold the driver is, I mean, you know, that's one of the funny things about teaching is you have to think to yourself, how do I hold that? Because it's just an instinct at this point. But you don't want to hold it this way, but you don't want to hold it this way. You want to have it in between, and you usually got your ring finger in there.
Okay, so like that?
That's good.
That's okay?
Yeah.
Okay.
Okay, how's my needle? Is it on it? Not the best. Let me move it for you a little bit.
Okay. All right.
Okay. And now this way.
Okay.
Okay. So just on one side and on the other. Yep. So hold it. And then make your... See how that's the example. See, it's not going to go in. People do that all the time.
Right.
But you need to point it in.
Okay.
And then let the curve come around. That's good, that's good. Okay. And pick it up. Just the needle.
Pick up
Yeah.
the needle. Okay.
Let go
Let go.
of this.
Do you
You
have
just
to pull
undo
it
it.
apart?
You have to,
Oh,
yeah.
okay.
It's probably a little bit sticky.
Oh,
Yep,
there we
that's
go.
good.
Okay.
That's good.
Oh, whoops. Okay.
And
And then
grab it again. Yeah. That's good. Then lift with this so that you know where you're going, so you can see. Yep. And then, and so try to make it about the same, you know, distance from the skin, from the edge of the incision.
okay. Ah,
Yeah, they're a little tricky.
it's awkward.
Mhm.
Okay. So just up there.
That's good. Yeah.
Okay.
And then, yeah, have it like curl around. So there's a good example. You don't want to be pulling it out like this. You want it to come around the natural way that it's going to come out, right?
Okay.
Okay. Now I'll tie the knot for you.
Okay.
Okay, so we're going to use the instrument tie because we're a little bit short, so this would be a perfect thing because it would be hard to tie this. The other thing that we could do, maybe I can do that for you since I've demonstrated the one-handed tie and the instrument tie. I'll demonstrate the two-handed tie for you. So we're finished with this needle. We put it in a needle box. This is the kind that they use in the operating room, and again, this is one that was opened and not used, so it got saved for us to use. And the nurses, there are numbers, so they keep track of all the needles that have been used, right? Often there's just a big plastic container, like a milk jug, and that's where the sharps are put.
Right.
Yeah. Mm-hmm. So here we are. We got the two ends, and we're going to do the old-fashioned. Can you do a reef knot?
It'd be better if you did it.
Left over right and under, and right over left
Right.
and under. And so you can see the knot there. That's the.
Okay.
You'd see it nicely if it were the
Okay.
The
Right.
shoelace.
if the shoelace, but that's a
Yeah.
surgeon's knot there.
Okay.
There we are. So then we can imagine. So they do usually interrupt. It's hard to. It's actually hard to demonstrate that what's called that subcuticular, that running method on this. And that's why we use the animal feet to demonstrate that, because it's got more of the layers of the skin.
right. Okay.
So
Right.
there we are. We can imagine that we closed all the rest of it. Good. So what questions have you got? Oops.
I think we asked a lot of them during the session.
Yeah.
Okay.
So if we had the muscles a color, so red, preferably.
I don't think
would
it's
it
that
be?
important, but it
Uh-huh.
would be fun
Uh-huh.
if you happen to.
Yeah.
I don't know that it's worth dyeing them all. But
That's what I was thinking would be the first thing. You could just dye that most recent elastic we've gotten. Yeah.
I mean, it might be worth a try, because then it gives that visual distinction that
Right,
that it is
right.
something different.
But
so.
the canvas color is okay?
It's perfect,
Okay.
because that layer is kind of white
Okay.
like that. Yeah, that's perfect.
And how well do you think this sort of emulates the actual human body? I mean,
It feels different,
Yeah,
you know.
obviously.
Yes, but it's such a good way to practice, because it's like no animals were harmed, right? Because you can take the needle out and put it in and say, no, not that. I mean, not that you say that way. I don't mean that, but you've got the opportunity for correcting things. You can do it all over again if it doesn't work right. And it is. I mean, it's a wonderful little demonstration. But they're just like thrilled with the idea that they get to practice
So who
doing
do
it.
you
So.
normally teach in the courses then?
Well, it's different in different places depending on the need, but say in Uganda, we'll be teaching interns.
Okay.
And these interns will be 3 months on the obstetrics and gynecology service. And after their whole year of being an intern, then they go out to, it's like a service period, they go out to a district hospital, and they're one of the very few people that are there. They don't have much supervision, and they can, what they're able to do, they can do. So they could save a life if they can do a good cesarean section. So they're really motivated.
Yeah.
They want to learn, and they want to do it well.
And how long are the courses that you normally teach?
Well, this particular course, the C-section course, is 2.5 days
Okay.
of classroom and simulated models. And then after that, they do cesarean sections in the operating room on real patients.
Wow.
With the real obstetrician on the other side, giving them the clues. And actually, after they do the course, we're going to have it that the student makes an appointment with their mentor to do one with that doctor from the very beginning, just like what we've done on the model, from the very beginning to the very end, all the way through the layers, and just to make sure that he or she is comfortable and that the mentor gives the A-OK, and then they do their cesareans. And so usually the first 3, the obstetrician, or it might be like a senior resident on the other side, but usually it's the obstetrician, they might get the baby out. Maybe there's some sense of urgency or something, and they don't want the learner taking their time doing that. But once the baby's out, then they sew all the layers closed. So they might do the first few that way, and then until they're catching on. So.
In terms of this model and just your struggle to get the baby out, is there anything that we could be doing? Should this be a
I
little
should have
bit
made the
bigger?
incision. I should have made the incision bigger.
Okay, but in terms of the actual size of this?
Oh, no, it's fine.
Okay.
It's fine. And some of it, I should have made the incision bigger is part of it. But part of it is just that these are plastic things and they're not supple, you know. There are times when it's really hard, particularly somebody, say, that's had a lot of, maybe they've had 3 cesareans before, and there's a lot of scarring. And a lot of scarring, it doesn't have the same kind of give.
Right.
But generally, there's lots of give in real life.
Yeah.
And so it's not. So it's just. I think it's just the matter of the model,
I
and
guess
that's
there's
okay.
A lot of lubrication and stuff as well.
Yes,
obviously, so.
exactly. And we
right.
don't have. I mean, that's one of the things that we do when we're practicing deliveries with the pelvic model. We use baby powder. So that the baby will slip out more easily,
Right.
because it's the same. It's plastic against
Yeah.
plastic, and those are hard deliveries to do. Yeah. Sometimes I've had people say to me, "Okay, well, when I really got to the human part, it was easy, and the model was so hard."
Right.
So once again, I'm Dr. Lorraine Woolford. I teach this course with African colleagues. It's not me that's doing the teaching. We use a train-the-trainer approach. The first time we go, we have an instructor's course that goes over not so much the subject, like the content, because they're experts already. They're all obstetricians, but it's to go over the techniques that we use so that they can become familiar with the models, etc. So the course is called the Structured Operative Obstetrics course. The models have been constructed here in the CNIS office in Vancouver, and I am taking these home with me today. The volunteers have made all these abdominal walls and uteruses. I'm taking them home tomorrow, and then I'll be going to Uganda at the end of next week to do another course or 2 in operative obstetrics.
My name is Deb Rudo. I'm a volunteer here at CNIS. I'm a retired graphic artist, and I work on sewing the obstetrical models.
My name is Alida Fernhout. I also volunteer for CNIS, sewing the obstetrical models, and I'm a registered nurse in my other life.
And I'm Milena Semproni. Again, I volunteer with CNIS making the obstetrics models, and I work as a student services coordinator at an ESL school.
I personally love Africa. I've lived there, and this is a way to use some of my skills that will hopefully improve the life of women and children in Africa and improve skills for African surgeons.
It's just a fantastic opportunity to share something that I can do and have it mean something in the world.
Yeah, I've also traveled in Africa and came away with just such an amazing experience, and it's something, exactly, that I can use, a skill that I don't normally use to make a bit of a difference.
Can I add too? It's amazing when you're there and people say, You've made these. Well, I say, no, it's not me, it's the volunteers, but that they've made them for them. I mean, they're just, so appreciative of the effort that's gone into it. And just to echo what you were talking about the importance of this, more than 500,000 women die from complications of childbirth every year. It's the equivalent of between 3 and 4 jumbo jets going down every single day. Like every single day. Like that's what should be in the paper, right? Imagine when one plane goes down, how much attention it is. But it's more than 3 jumbo jets filled with women dying every single day. A timely cesarean section is one way that some of those deaths, not all of those deaths, but some of those deaths can be prevented. So I appreciate your work.